Phabetome, forceps-assisted blade incision twin optimized MICS emulsification. For performing a perfect phaco-emulsification, precisely created incision serves as a master key and calibrated curvilinear capsular excess facilitates as a perfect lock to optimally seal the anterior capsule rim onto the equator of an implanted foldable IOL in its designated effective lens position in situ. There is a great deal of variability in how surgeons create the clear corneal incisions and central curvilinear capsular excess, and to what extent the phaconeedle tip is embedded into the cataractous nucleus. This variability lies directly in the surgeon's hand and brain coordination. The whole world agrees to the fact that humans are more powerful than any other machine available on this earth. Calibrated Phabetome phaco instrumentations, which includes 2.5mm, 2.75mm, 3mm radius marked capsular excess forceps and radius marked needles, rexus marker, marked iris repositor, marked phaconeedles and twin marked MICS blades for 1.8mm and 2.2mm with appropriate incision width measuring gauges, which leads to a potential improvement and precision in terms of phacosurgical steps like calibrated corneal micro incisions of 1.8mm and 2.2mm capsular excess performed with calibrated forceps with radius marking at 2.5mm, 2.75mm and 3mm, or with needles of similar radius markings to achieve a target rexus diameter of 5mm, 5.5mm and 6mm. Coaxial microphaco needle has circular calibrated etched bands to visually aid the phacosurgeon to limit the embedding of its distal tip portion during the phaco chop procedure. The etched bands marked at 2.4mm, 2.6mm and 2.8mm guides with a safety margin to embed at a measured depth in cataract grades of 1, 2 and 3 respectively, provides better leverage during the phaco chop procedure. A clear corneal incision is created in all the 3 patient groups with pre-calibrated twin-marked blades of 1.8 and 2 mm. Other blade has markings indicating 2.2 and 2.4 mm. The positioning, circularity and central point of the rexus is achieved by initial reference marking on the anterior surface of the cornea with the rexus marker, which creates a circular impression. With the circular marking as reference, an approximate central point to initiate the capsular rexus is marked by visually ascertaining a location on top of the anterior capsule for the initiation point reference. With a calibrated radius marking of the forceps positioned at the initiation point, reference marking for the forceps tip is closed and a mark is placed for the desired dimension of the target radius to be achieved. With these 2 reference points, the initial tear of the anterior capsule is executed to create a capsular excess in the required diameter. While performing a capsular excess after completion of each quadrant, the point of the forceps tip and the calibrated marking is oriented in such a way to measure the target radius from the central reference point. To measure the capsular excess diameter, an iris repositor is marked with graduations starting from 1 mm to 6 mm. This is inserted through the primary incision and the side port incision. This measurement procedure eliminates parallax error and ascertains exact 5 mm diameter measure of the centered capsular excess with a 2.5 mm radius marked forceps. Similar procedure is adopted with the pre-calibrated 3 mm radius marked capsular excess needle to obtain an exact 6 mm diameter excess as indicated and measured with a marked iris repositor under a 1.8 mm micro incision. This is to rule out any possible difference between the 2 capsular excess instrumentation used by the same phacosurgeon. The cut anterior capsular flaps are carefully taken out of the anterior chamber and immediately reconstructed on top of a microglass slide, adding few drops of glutaraldehyde solution and leaving it for a few minutes for its structural dimension to be frozen forever, and it is further stained with a blue dye and taken up for its instant measurement with a scientific scale to confirm its diameter in two different axes. This capsular flap from 5 mm diameter rexus reconfirms its dimension, and the other flap also reconfirms a 6 mm capsular rexus performed for the patient. Capsular flaps are observed under the scanning electron microscope to confirm their circularity with exact dimensions of the flap diameter measured across two different axes. With the observation and analysis of these measurements, most of the capsular flaps observed under the SEM reconfirmed the targeted rexus diameter is achieved. Even the circularity is also observed in most of the flaps except a few which were torn during its reconstruction process as indicated in these SEM images. The pre-calibrated marked phaco needle tip is used to visually aid the operating surgeon to limit the depth of its distal tip penetration level into the nuclear substance with the 3 different rings marked to embed in different cataract grades. The MICS incision width is increased from 1.8 mm to 2 mm or 2.2 mm to 2.4 mm for a comfortable wound-assisted implantation procedure. Inevitably, better results are consistently obtained in all the patients with quick, self-sealing calibrated incision. Micro-level accuracy of capsular rexus ensures an effective lens position in the capsular bag with perfect centration of lens. Post-operative slit lamp images of 3 different patients implanted with the same IOL model indicates that diameter is measuring 5 mm, 5.5 mm and 6 mm. Circular centered capsular rexus could be achieved. Conclusion: this technique uses cost-effective regular instrumentation during the phacoemulsification performed under micro-incisions of 1.8 mm or 2.2 mm MICS procedure. Appropriate calibrated marks for guiding the phacosurgeon in real time to achieve their target measure of corneal incision valve, capsular rexus dimension and predictable depth of phacotip embedding. Instead of subjecting the intraocular tissue to an extra laser energy, proven and safe micropulsed ultrasound energy is utilized for phacoemulsification with repeatable, consistent intraoperative and post-operative end result obtained in all the patients with 100% surgeon's hand scale.